what is an MS relapse? Many of you in the room will know this better than I do, but definitions vary. The most widely accepted clinical definition is this one by Schumacher, and that is that a relapse is new symptoms or a significant worsening of existing symptoms that persists for more than 24 hours and is in the absence of any infection. Of note, the symptoms should be significant and they can be variable from person to person. So in one person, it could be a tingly foot, and the other person, it could be an optic neuritis. So they do vary, and that's what makes it quite difficult, but they should be focal. So a change in cognition or something vague will not count. A relapse should be preceded by 30 days of clinical stability. So a sensory symptom in a left foot, and then a week later, sensory symptom in a right foot, is still counted as one single relapse. And from this definition, an MRI scan is not required. So it can be purely clinical. It can be nice to have an MRI and give you a bit of confidence in your diagnosis, but it's not necessary. So who gets relapses? They're not exclusive to relapsing remitting MS, and we should remember that these terms, relapsing remitting MS or primary progressive MS, we're trying to box patients in to meet what we want to label them as. So anybody with a diagnosis of multiple sclerosis can have a relapse. It just represents an active disease. And patients with progressive MS or a label of progressive MS can also have a relapse. So I'm going to talk about two things that are common, and we certainly get commonly asked about. Could these symptoms represent a relapse? The first is pseudo relapses. So these are worsening of pre-existing symptoms in the context of an infection or the context of something else happening in the body. Pseudo relapses are thought to occur and to represent a conduction block whenever there is an increase in temperature, for example, a fever. This can reduce the conduction velocity in the nerves and unmask previous symptoms. So to have a pseudo relapse, the patient should have had similar symptoms before. That can be at the very beginning at diagnosis, or it could have been during a previous relapse, but the symptoms should not be brand new. And the other thing that we get asked about whether this could represent a relapse is day-to-day variation and fluctuations. This is very common, and patients come to clinic and report that some days they feel well, some days they feel less well, and does this mean that they're having multiple relapses? And it's not the case. Again, often once the nerves are damaged, the pathways are susceptible to further damage, and we can see an increase in temperature or anything else can unmask previous symptoms. And this is not an episode of new demyelination. And it's important for several reasons to differentiate relapses from these pseudo relapses. The first is that the management of the two differs. Management of pseudo relapses is just as important, and I think sometimes in neurology we forget that. We think, oh, this is not a relapse, send it back to the GP, let them sort out the problem, but it's not a relapse. I don't think that's right. It has implications when we are trying to categorize patients. So if we're wondering whether a patient should remain on a disease-modifying treatment, are they still relapsing? Then we want to know whether they're having real relapses or whether they're having pseudo relapses. And it's very important if we're considering escalating disease-modifying treatments and wondering whether a patient's failing on their current disease-modifying treatment. If they're having 3 relapses in 1 year, that's very, very different to if they're having 3 pseudo relapses because their suprapubic catheter is infected. Those are very different scenarios. So relapses may be treated with steroids. I was going to say that we tend not to treat mild relapses, but after Klaus's talk, I'm scared to use that term. So we don't use steroids for every relapse. Steroids have significant side effects, and we don't want to use them unnecessarily. When we do use steroids, they can be intravenous or they can be oral. We can give 5 days of 500 milligrams of methylpred or 3 days of intravenous methylpred. And pseudo-relapses are managed in a completely different way. So you obviously need to manage the underlying cause, and that could be a urinary tract infection, a respiratory tract infection. So if a patient has urinary tract infection, they may require antibiotics. If they have multiple urinary tract infections, we should maybe consider why are they having this? Do they need to be seen by a urologist? Do they need to be seen by the incontinence team? So pseudo-relapses should be considered more than just treating that infection, but looking for the cause of it, because they do have significant morbidity as well. So this is a graph. It probably doesn't project well at all at the back, but basically, if a patient presents with a new symptom or a difference in symptom, is there evidence of infection? And that can be very easily checked in the community, in the GP surgery, even at home, with a urine dipstick test. If there is evidence of infection, so on the right-hand side, is the urine dipstick positive or are the symptoms suggestive of infection? Then that's probably a pseudo-relapse. So you might want to treat with antibiotics or monitor, see if the symptoms get better. If they do not get better, remember to reevaluate. The patient can have a relapse and a urinary tract infection at the same time as well. So consider a pseudo-relapse, monitor, treat the infection. If a patient presents with a new symptom going down the left-hand side and the infection has been excluded, so they're well, they have no evidence of a urinary tract infection, their chest is clear, are the symptoms from their relapse mild? Maybe a tingling in a left foot, no weakness, their mobility is not affected, in which case do you really want to give them steroids, potentially side effects, maybe just monitor, see how they go for a few days, reevaluate. If they have a significant relapse, if it's weakness of their right hand and they're right-handed, then steroids can quicken that recovery. They won't change the ultimate recovery from the relapse, but they may quicken it, which obviously can be helpful in getting a patient back to work or improving their mobility. And also, if it's a significant relapse, they may require physiotherapy, they may require an inpatient stay, and that may have implications for their disease-modifying treatment, whether that should be escalated or not. So I thought I'd do some case examples. You can shout out, buzz in whenever you think you know. They're very simple. So the first is a 35-year-old male who was labelled with relapsing remitting multiple sclerosis 5 years ago on an injectable first-line disease-modifying treatment, so all very standard. Last relapse was 2 years ago, and now he comes to you and he says he's got a pain behind his right eye. It's worse when he moves his eye, he's got a bit of blurred vision, and this started 2 days ago. Got no other symptoms, otherwise feels quite well, but the pain in his eye is bothering him. So what do you think? Hands up for relapse. Okay, yeah. Hands up for pseudo-relapse. Hands up if you're not sure and you're just hungry and you want me to finish. Yep, right. So basically, he's on a disease-modifying treatment. He's got a brand new symptom, suggestive of optic neuritis, so inflammation of the nerve in his eye. He should probably get steroids. So second case, we've got a 40-year-old lady, relapsing remitting MS for 10 years, and she's on a medication for that. You can choose a second-line DMT. Her last relapse was 5 years ago, so she's been stable for a while and she's on good medication. She comes with tingling in her left leg. It's mild. She's not sure if it's maybe a little bit weak. She can't really tell. It feels a bit funny. And she has had similar symptoms before affecting that leg. At the same time, she's noticed a change in her urinary frequency over the last few days. Hands up for relapse. Pseudo-relapse? Yep, excellent. Okay, and finally, we've got a 50-year-old lady diagnosed with relapsing remitting MS about 15 years ago, and her last relapse was 7 years ago, so she's been stable or she's not had any relapses for quite a while. She was on disease-modifying treatment and it was stopped because she hadn't had any relapses. She was thought to be secondary progressive. And she now comes to you, it's been cut off, she now comes to you with new symptoms. She's never had them before. Let's say it's weakness of her right leg. It's affecting her walking. She's nearly fallen a couple of times. Never had this before, not on any medications. Hands up for relapse. And she's secondary progressive. Does that bother anybody? Nope, nope, good. Hands up for pseudo relapse. No, excellent. Okay, brilliant. All experts. Right, that's me.